Okay guys, Timmy coming at you again. And in our previous video I explained to you the oxyhemoglobin dissociation curve, and that's a fancy way of saying how does oxygen know to bind to the iron on hemoglobin in the lungs and let go when it gets down to the cell. So I explained that to you. Again, let's review a couple of things just real quick. Number one, PO2 is the amount of oxygen dissolved in plasma. And PO2 is important because PO2 in a lot of ways determines how much oxygen gets bound to the iron on hemoglobin. And again, the normal PO2 is 80 to 100. And since most of us live in a region where the PO2 in the atmosphere is enough, where when that air gets down to the alveoli, come on, the PO2 is somewhere between 80 and 100. And that's what you want. So again, let's look at this for a minute. If you look at a PO2 of 80 and then a PO2 of 100, and again, you can't get greater than 100% saturation of red blood cells. The PO2, or the amount of oxygen dissolved in the plasma of the blood, and how that correlates with how much oxygen is bound to the iron on hemoglobin. And the amount of oxygen bound to the iron on hemoglobin is a percent saturation. So when they put the little clothespin on the patient's finger and they have that little infrared light, what they're actually measuring is the percent of oxygen bound to the iron on hemoglobin. And that's the best way to transport oxygen. So having said that, let's look here. As you can see, as you decrease the PO2, as the PO2 decreases, then the amount of oxygen bound to the iron on hemoglobin decreases. So if you look, we talked about the fact that the PO2 inside a cell is about 40. So let's look. So if you draw that up, I'm going to draw a straight line. The PO2 inside, or the oxygen saturation of venous blood after it has dumped off its oxygen, is about like 70, 72. That's the percent of oxygen that's still bound to the iron on hemoglobin. So venous blood still has oxygen attached to it. That's why doing CPR without the rescue breaths, you are circulating that venous blood around and there's still oxygen attached to it. So if you look, if you had 98% and then it drops down to 70%, right? How much oxygen was actually dropped off? About 28% of that oxygen was dropped off. But if you look at how the curve works, between PO2s of like 80 and 100, that's good, right? You ain't going to do better than that. But as the PO2 begins to drop below 80, and if you look with a PO2 of 60, right, you only have about 85% saturation of that red blood cell. So in order to get that 28, right, then doing the math in my head, right, that's 63. So the saturation of venous blood now becomes 63%. So, but this is really important. When you start dropping PO2s below 60, the curve begins to drop steeply. That means that when you have PO2s that are lower than 60, the hemoglobin is very, very difficult to saturate, and you are not delivering enough oxygen to those red blood cells. So the curve helps you understand how PO2 affects hemoglobin saturation. Now, let's look for a minute, right? Let's look. We're going to look. Just you wait. So what could cause some problems in terms of the blood desaturating? Well, let's look. Here you have a bronchiole, right? And you have the terminal bronchioles. And then you have the alveoli, right? So let's talk a little bit about chronic bronchitis. In people with chronic bronchitis, a couple of things happen. Number one cause of chronic bronchitis, smoking, cigarettes, long term. And smoking does a couple of things. Number one, it paralyzes cilia. Cilia are the little conveyor belt that move the mucus blanket produced by goblet cells from the lower airways to the upper airways, where you get rid of that stuff. So cigarette smoking paralyzes cilia. Number two, it causes increased size, hypertrophy of goblet cells. So the goblet cells get bigger, and what do goblet cells produce? Goblet cells produce mucus. So what happens? We'll make it green. The mucus starts clogging the airways, right? So you get this mucus, gooey mucus in here, right? So here's the problem. You got an alveoli here, and you got a pulmonary capillary here. You got an alveoli here and a pulmonary capillary here. The problem in people with chronic bronchitis is there is a ventilation perfusion mismatch. Basically what happens with this mucus production is there is no way air can get to this alveoli. It can get to this alveoli, right? So let's say the PO2 here is going to be 100. The PO2 here, nothing, because you ain't ventilating that. However, you are perfusing it. So wherever you see Q, you think of flow. In this case, blood flow. So you have the PO2 of 40, but you have no PO2 here. And what's the PCO2 of venous blood? If you remember, it's 45. So this blood is not going to participate in gas exchange. This blood will. So the PO2 of 40 here, right? The O2 is going to come in, and the PO2 of that blood is going to be 100. The PCO2 is still going to be 45, but what's the PO2 of this alveoli that's being ventilated? It's 40. So the CO2 is going to leave. However, all the blood from all the pulmonary capillaries meet at the pulmonary veins. So ultimately, you are going to be mixing blood that has a low PO2 because it didn't participate in gas exchange here, and a high PCO2. So the end result in people with chronic bronchitis is this. One, they will have a low PO2 and they will have a high PCO2. Now, If you recall, I'll draw a quick little picture. I don't like this erasing. So what's the problem again? They have a low PO2 and a high PCO2. Now, the part of your brain that controls breathing is the medulla oblongata. And the medulla oblongata, MO, has chemoreceptors on it. So the medulla oblongata will signal, electrically stimulate the phrenic nerve that will cause the diaphragm to contract, and you will inhale. Now, what's the stimulus for breathing? Well, the medulla oblongata is in the brain, and circulating around the brain is this stuff called cerebrospinal fluid. And normally, as carbon dioxide builds up in the blood, CO2 diffuses from the blood into the cerebrospinal fluid. This is important. And CO2 will combine with water and form our lovely equation, carbonic acid. And then carbonic acid then dissociates, breaks apart into bicarbonate ions, HCO3 with a negative charge, and hydrogen ions. And it is the hydrogen ions that directly stimulate the adrenal medulla. However, in people with chronic bronchitis, the medulla is chronically exposed to elevated CO2. So what happens is there is a downregulation. These a fancy way of saying that there is a decreased sensitivity of these chemoreceptors to carbon dioxide indirectly and hydrogen ions directly. So I'll simplify it even further. People with chronic bronchitis, their stimulus for breathing is no longer CO2. But you learned, and I will never forget it. I think it was a Tuesday. That embedded in the arch of the aorta and in the carotid arteries, you have carotid bodies and aortic bodies. These are peripheral chemoreceptors. And these peripheral chemoreceptors are sensitive to drops in PO2, increased hydrogen ions, right? That's another way of saying decreased pH or elevated PCO2. So with the central breathing control center, the medulla being desensitized to the elevated CO2, people with chronic bronchitis no longer breathe. That's no longer the stimulus, but peripheral chemoreceptors take over, and they respond to drops in PO2. So this is why you have to be careful giving oxygen to a patient with chronic bronchitis. And the reason is that their stimulus for breathing is low PO2. So if you give them supplemental oxygen, the PO2 is going to go up. And if the PO2 goes up, then it will not stimulate aortic bodies or carotid bodies, and they will stop breathing. That's why low levels of oxygen are given to people with chronic bronchitis, not high levels, because their stimulus for breathing is oxygen due to that ventilation perfusion mismatch. Okay, from a clinical standpoint, then you understand, or at least should begin to understand a little bit about why people with chronic bronchitis shouldn't be given a lot of oxygen. Now, let's get back to our little oxyhemoglobin dissociation curve. Explain why that's important. All right, let's look. In clinical, they speak to you about a left shift and a right shift in the oxyhemoglobin dissociation curve. So I'm going to try and explain that if I can find where I put the oxyhemoglobin dissociation curve. There it is. Okay. All right, so watch. When you look at this here, here's the normal physiologic levels. And we talked about the fact that if you look, what are the levels, what are the conditions at the cell? Let's review that. There is low PO2. There is high PCO2. There is elevated temperature, right? Elevated heat temperature. And there is low pH, right? Or that's another way of saying increased hydrogen ion concentration. All of these things, all of these conditions cause oxygen to fall off the hemoglobin, so it dissociates. And if you have these conditions, not just at the cell, but in the entire body, so you got a fever, or you got high PCO2 because you got pneumonia, and you got low PO2 because you got pneumonia, and you've got some condition that's causing your pH to drop. If those conditions are present all over the body, that's going to cause the curve to shift to the right. So if you think that when a curve shifts to the right, that those are the conditions present at the cell. What are the conditions? I just want to explain them to you. So what that means is that for any given PO2, when the curve is shifted to the right, that means for any given PO2, the oxygen saturation of a red blood cell is going to be lower. Now watch. Let's take a PO2 of 80. Under normal conditions, what's the saturation of a red blood cell? About 95. If you shift the curve to the right, a PO2 of 80, it's going to drop the oxygen saturation to less than 90. So what that means is that for any given PO2, when the curve is shifted to the right, that the amount of oxygen bound to the iron on hemoglobin is going to be lower. So let's now look. We got the curve shifted to the right. What's the PO2, or what's the oxygen saturation in the lungs? About 89. What's the PO2 inside the cell? 40, right? So if you draw up a little line there, you're going to see that the oxygen saturation of a red blood cell is going to be 60. So in order to get the amount of oxygen needed by the cell, you have to have a greater difference between the oxygen that's saturating the red blood cell in the arterial blood and the PO2 inside that cell. So very simply, when a curve is shifted to the right, oxygen lets go at the cell, right? But it has a hard time binding it can't bind to the iron on hemoglobin in the lungs. So what does that do? That effectively decreases the amount of oxygen that you can deliver to the cells, right? Because the conditions throughout the body are the conditions that are normally present at the cell that will allow oxygen to fall off the iron on hemoglobin. The problem is if those conditions are all over, including the lungs, then oxygen won't be able to bind in the lungs. So you're effectively decreasing the amount of oxygen delivered to the cells of the body. Now, that's a right shift. If you look at a left shift, what does the left shift tell you? The left shift tells you that throughout your body, you have conditions throughout your body that are similar to the conditions in the lungs. So what are the conditions in the lungs? Well, there's a lower temperature because the cool blood from the non-metabolically active parts are going to mix with the hot blood from the metabolically active parts, effectively decreasing your body temperature. There's going to be an increase in pH because you are removing CO2, right? And CO2 is an acid. So anytime you get rid of CO2, the pH is going to go up. Don't worry about DPG. That's diphosphoglycerol. I don't want to talk about it. Right? And what do you have also at the lungs? You have a higher PO2. So all of these situations, if those situations are consistent throughout the body, what that means is that for any given PO2, let's look, the PO2 when you have a left shift is almost 100% in the lungs. What's the PO2 of the cell? It's 40, so draw up a little perpendicular there. And the oxygen saturation of a red blood cell goes to about 83, 84. What that means is this, is that if you have a left shift in the oxyhemoglobin dissociation curve, you have conditions that you find in the lungs normally. And what conditions do you find? High PO2, higher pH, lower CO2, and a lower temperature. So any of those conditions that are present throughout the body now, let's say they're hypothermic, right? Their body temperature is dropping. They will be able to bind oxygen to the iron on hemoglobin in the lungs, but it won't let go at the cell. So you've effectively decreased the amount of oxygen you're delivering the cells. If they are alkalotic, their pH is an alkalosis, oxygen will bind to the iron on hemoglobin, but it won't let go. And if you have a patient on a ventilator and you are delivering, their PO2 is 300, right? That high PO2 may look nice as you're drawing arterial blood gases, but rest assured that the amount of oxygen that you're going to be delivering the cells is actually lower because you're causing that curve to shift to the left. So that's the important thing. And the other thing to remember is that once you drop below a PO2 of 60, you are significantly desaturating red blood cells where those people will be hypoxic. That's why. And with a PO2 of 60, normally you have an oxygen saturation of about 85, right? So when the PO2, when you put the little thing on your finger, the little clothespin, and their oxygen saturation is 75, these people are not getting enough oxygen. What could cause that? Several things, right? The inability to transport that oxygen from the alveoli into the blood, or, that's respiratory, or a decrease in the heart's pumping ability to get that oxygenated blood down to the cells of the body. So I hope that helped, and we'll see you.